Good afternoon, and thank you for joining us for part two of our webinar series on understanding the Inflation Reduction Act and upcoming changes to Medicare. We are so happy that all of you could join us today. I am Tiara Green, President of Accessia Health, and your moderator for today's session. Before we get started, I just have a few housekeeping items to cover. First, all lines are muted throughout the duration of the webinar. However, if you have a question, we welcome you to submit those through the Q&A section on your screen. We will have time at the end of the presentation to answer your questions. And for the convenience of some of our viewers, closed captioning has been turned on, and this webinar is being recorded and will be available on our website at accessiahealth.org. Accessia Health webinars, events, and conferences are intended to provide information to the public. The views and opinions expressed by any speakers or other third parties are not necessarily those of Accessia Health. I'd like to spend just a few minutes to talk about Accessia Health. We are a national independent charitable patient assistance organization assisting those with rare and chronic conditions accessing their care. We are proud to have over 80 programs established in a variety of condition areas, rare diseases, respiratory conditions, neurological, and cardiovascular. Our assistance extends beyond just copays for medications. We assist with health insurance premiums. We also assist with out-of-pocket costs for labs, medical visits, durable medical equipment, as well as travel to access those therapies. In addition, sessions such as this offer educational opportunities for individuals to make informed healthcare decisions, giving them crucial information so they can do so. In addition, we also provide case management, helping individuals understand their health insurance coverage and the opportunities or available plans. Without further ado, I'm excited to introduce our speaker for today, William Sarraille, or also known as Bill Sarraille. Bill is a nationally recognized expert in healthcare and life sciences, bringing decades of expertise to the intersection of patient advocacy and healthcare law and policy. As founder of Sarraille & Associates, he provides strategic consulting to patient advocacy groups and others on an array of topics, including Medicare and Medicaid reimbursement, clinical trials, healthcare affordability issues, and more. A trusted advisor to Accessia Health, Bill also serves as a professor of practice at the University of Maryland Francis King Carey School of Law, and as general counsel to a patient assistance or patient access organization. He also holds a board position with the Rare Disease Advocacy Group. Consistently recognized by the best lawyers in America in Chambers USA for his excellence in healthcare law, Bill has co-authored several healthcare books. His work combines legal acumen with an unwavering commitment to improving access to essential healthcare services. We welcome and thank you, Bill.
Thank you so much. Well, I have to apologize because you're going to hear my two dogs in the background. Unfortunately, they are very upset at the fact that my lawn is being mowed, but we'll try to ignore that and push on into this session today. We're going to talk about a series of really important changes to Medicare Part D that affect the coverage that you're going to receive under that program. So if you go to the next slide, I'll give sort of the overview, the perspective that I have. Almost all of the changes that I'm going to talk about are very positive at their core, but there are unfortunately some circumstances, some potential that some of these changes could have an unintended negative effect. So I'm going to try to give you the straight talk here, talk both about the positives that you should anticipate and expect, and a few negatives that you should be on guard for. So my purpose is to make sure that you get the most out of the positive benefits of the Inflation Reduction Act, and that we minimize any problems or challenges that you might face as a consequence of this change in law and the regulatory implementation of it, which is really kicking into high gear here as we approach January 1 of next year. Okay, with that, let's go ahead and get started. This is the range of issues that we're going to talk about in our time together today. The first topic that we're going to talk about is Extra Help. That program, which provides a terrific set of benefits to those patients who qualify, have been expanded by the Inflation Reduction Act. So if you qualify for Extra Help and have not already enrolled in that program, that is something that you can do today to really help get the most out of this benefit for you. We're also going to talk about a $2,000 out-of-pocket cap on all of your out-of-pocket costs that are associated with the Medicare Part D program beginning January 1 of this year. Next, we're going to talk about smoothing, or M3P. This is the worst named Medicare program ever, but it could be a very beneficial program for you to the extent that you have a lot of out-of-pocket costs under Part D at the beginning of the year, or maybe even the middle of the year. This is a way to smooth out those payments over the course of up to 12 months and provide a little more affordable costs from a month-to-month basis. Then we're going to talk about something called premium stabilization, which is going to reduce the premiums that you otherwise would have to pay if you have a Medicare Part D standalone plan. We'll talk about what those are a little bit later. Then we're going to reinforce some of the already implemented components of the Inflation Reduction Act, which you might not already have taken advantage of. That's the inflation cost sharing cap and a series of vaccines that are going to be provided at no out-of-pocket cost at all. Then we're going to talk about something called the inflation penalty provision of the Inflation Reduction Act and how that could affect, in a very beneficial way, the copayments that you're responsible for under the Medicare program. And then last, we're going to talk about the provision that maybe you've heard the most about in terms of what the Inflation Reduction Act does for Medicare Part D. That's the Medicare negotiated prices provision. And that too has potentially a beneficial impact for you at the pharmacy counter, but not this next year. It'll only be the year after that that will kick in, but we're going to give you sort of an early preview as to what that might mean for you. Okay, so that's our big picture and our outline. Let's jump into the first one, Extra Help, which is also known as low income support. This is something that was already effective in 2024, but unfortunately, lots of people, up to 3 million beneficiaries, haven't taken advantage of this very important change. This Extra Help, or low income support, is the best of all the possible options for help. So we're going to go through a whole bunch of other ways that you can get assistance through the Medicare Part D benefit design with your copayments, with your out-of-pocket costs. But this one that we're starting with is the best of all possible options if you qualify. Why is it such a great deal? Well, for most qualifying patients, it means that you would have no Medicare Part D premiums, no Medicare Part D deductibles, and fixed lower copayments. In the case of a generic drug, no more than $4.50 for each generic drug. And in the case of brand name drugs, no more than $11.20 for each of those brand name drugs. So very good deal if you qualify. All right, next slide. How do you qualify? Well, basically the test is that you and your family unit living together have to have 150% of the applicable federal poverty income limit or less in order to qualify. So the 2024 federal poverty limits, depending upon the size of your household, are listed there, both in terms of monthly income and yearly income. So if your monthly and yearly income are below those numbers and you haven't already signed up for extra help, you should take a look at this next slide. Because these are the ways that you can sign up for extra help, the way you can enroll in this special benefit. If you're comfortable using the internet, then here is the internet access address for sign up. If you prefer to call, then the number is listed there. And in addition, if you actually want to talk with someone live and go through a process with help right in front of you, you can go to any local Social Security office, ask for the paper application, schedule an appointment to go over that paper application with an employee from the Social Security office and make sure that your enrollment has been effective. So 3 different options, no matter how you would feel most comfortable exercising this option, there's an option for you. Okay, with that, we'll go to another option that is available to you to help with your out-of-pocket costs. Starting this January 1, we have great news by virtue of the Inflation Reduction Act. That news is that as of that date, your yearly out-of-pocket costs can be no more than $2,000 for Medicare Part D drugs. This is a huge and very positive change for the 1.5 million Part D beneficiaries who have, at least as of this year and prior years, been the subject to out-of-pocket costs that unfortunately have exceeded $2,000. If we go back several years, some beneficiaries unfortunately were paying $5,000, $6,000, $7,000, $8,000 a year. So this is a huge and very positive change for those patients. Indeed, if your plan has already made a commitment to do better than the standard Medicare Part D benefit with respect to your out-of-pocket costs, this cap may actually be even lower for you than the $2,000. So that's a fantastic source of potential support for lots of Medicare Part B beneficiaries who are dependent on a variety of different drugs. What do you have to do to receive this benefit? Well, that's even better. In this particular case, you don't have to do anything. The $2,000 cap, or to the extent that with respect to a particular plan, it's even lower than $2,000, is something that your plan will automatically apply itself. So even better, you don't have to do anything to take advantage of this important change that is brought to you by the Inflation Reduction Act. Okay, next slide. This is one of those things that we need to caution you about. There are some potential unintended consequences that might come from some of these IRA provisions, and here's the first one. So plans cannot, as a consequence of this cap, collect coinsurance and other out-of-pocket costs that exceed that $2,000 ceiling as of January 1. Well, that may lead some Part D plans to raise the out-of-pocket costs for that group of patients, unfortunately millions of patients, that were previously below that $2,000 cap as a way of trying to make up for some of the coinsurance and other out-of-pocket costs that they no longer are going to be able to secure from those patients whose costs were previously above the $2,000 ceiling. We already have seen that United Healthcare, the largest insurer in the country, has announced that as a consequence of the change in the $2,000 cap, will be raising for at least some of its plans the deductibles that it charges to patients in 2025. So what can you do here? Well, there are going to be plan changes as a consequence of some of these Inflation Reduction Act provisions. It's important to make sure, even if you're comfortable with your existing plan, that you understand what the situation is going to be for you next year. So go on Plan Finder. We'll have the information for that in a subsequent slide. Compare your plan and other plans. Make sure that the plan that you choose for next year is the right plan for you. Okay, with that, we'll move on and we'll talk about yet another option for helping you with out-of-pocket costs. This, too, is a function of the Inflation Reduction Act. This one does not have the best name. As I mentioned before, it's referred to in a variety of different ways, none of which really conveys what the program does and how it might help you. But it's called variously the Medicare Prescription Payment Plan, or most confusingly, M3P, or a little more simply, smoothing. And this is a new voluntary opt-in benefit that is designed to help those of you who may need or may benefit from smoothing or spreading the $2,000 that you may have to pay under the cap over the course of the year. Here's the basic concept here. You may, if you're on a particular drug, you may find that for January of this year, you go to your pharmacy and you're expected to pay perhaps as high as $2,000 on that first medication that you have dispensed in the year. So for a lot of people, obviously, that is way too big a cost, and certainly way too big a cost all at one time. So smoothing is designed to allow you, if you opt in, to take that $2,000 obligation and spread it over the course of the year in a way that makes, because now we're talking about monthly payments, the overall burden of what you would otherwise have to pay in one sitting that much more manageable. Okay, so it's a great idea. It can be a huge benefit to a lot of patients. And let's talk a little bit more about it in the next slide. So this is the example that we were talking about. Instead of having $2,000 paid in January under smoothing, if you opt in, you'll be able to pay that $2,000 not all at once at the pharmacy counter in January, but instead to smooth it over the course of the year. CMS has given some specific examples of situations where this benefit is attractive and can be likely to help an individual. So that's our example one here. This is directly from the Medicare program. It assumes that if you don't elect smoothing, that you would otherwise face a $500 out-of-pocket cost in January, in February, in March, and in April before you get to that $2,000 overall cap. Now, that's a lot in those first 4 months. So if you elect smoothing, what happens is you make an initial payment under this scenario of $166.67 in January, and then assuming that you don't add in other drugs with additional costs in the mix, you then have these various payments that follow through the remainder of the year. The low is $75.76 in February, and the high that begins to kick in April is $181.31. So it's a very complicated formula that applies here, unfortunately, which doesn't make for precisely equal payments for each of the months. But you get the idea that it does, in fact, in a significant way, smooth your out-of-pocket costs over the course, potentially, of up to 12 months. All right, well, the next slide gives a very different example where, because there isn't a lot of copayment costs at the beginning of the year, and those copayment costs are a little bit more manageable. In this particular scenario, $80 is assumed for each of the 12 months. Here, smoothing probably isn't that much of an advantage. In the first month, $80 under an unsmoothed approach is yielding $80 under the smoothed approach. You do get a benefit in February, but then that benefit erodes over time, creating less of a differential between the copayment that you would have otherwise paid without smoothing versus what you would pay with smoothing through August. And then in September, if you've gone the smoothing route here, you actually end up spending more to a high of $241.53 in December. So it's all about your particular circumstances as to whether this system, this mechanism makes sense or not. Next slide. So let's talk a little bit more about trying to figure out whether this makes sense for you or not. Obviously, that's the driver for whether you end up opting in this program or not. I wish I could say that if this did make sense for you, it was something that was going to be automatically implemented for you, or that if it made sense for you, you would be able to opt in at your pharmacy counter. Unfortunately, the Centers for Medicare and Medicaid Services didn't provide for that sort of functionality in at least the initial year of the implementation of the smoothing benefit. Essentially, the regulators determined that they had, in their view, too much to do in too short a period of time to build in this sort of at the pharmacy counter opt-in mechanism. So it puts the onus on you to decide whether this makes sense for you or not, and then to go ahead and opt in. But good news, there are some resources that will enable you to figure out whether this makes sense for you and assist you in making it a little easier to, in fact, opt in. So the primary mechanisms that you can learn more about this program and if it's right for you, opt in, are available through your plan. The plans, every single one of the Medicare Part D plans, are expected to provide multiple mechanisms to allow you to evaluate this particular program and to opt in. So one mechanism will be through your plan enrollment process as a consequence of the open enrollment period. There also has to be a paper option, and it's also the case that the Medicare Part D plans are expected to have an option for telephonic information about the program and opt-in through their regular toll-free telephone number. Finally, each Medicare Part D program is required to have a mechanism on their website that provides, again, both education and opt-in information. You will know if you successfully opted in because you will then receive a letter from your Part D plan confirming your participation in the smoothing program. Okay, next slide. Unintended consequences again. Unfortunately, there, as I've said, are times when, depending on your circumstances, this is going to be a great idea, and sometimes when maybe it won't be a great idea. So there are some caveats to think about in deciding whether or not to participate in this program. The first one, again, if I haven't said it enough, and I think I've already said it 5 times, is that if you think this is the right option for you, you're going to actually have to take the step to opt in. Again, unfortunately, it's not the case that you can simply wait until you get to the pharmacy counter and then opt in. It has to be an action that you take separate and apart from walking into the pharmacy and picking up your medication that month. Big picture, what I would say is that if you have higher costs earlier in the year, or at least through the middle part of the year, and your costs are significant. In that circumstance, smoothing is going to make sense for you. By the same token, if your costs are really directed towards the late, middle, or end of the year, and they're not that significant on a month-to-month basis, then this is probably a program that doesn't help you. It's a complication that you don't need to get into. So how things could go awry here a little bit. What happens under this program is that instead of paying at the pharmacy counter, you instead are going to get a bill each month, whether you receive a new prescription or not. You're going to receive a bill each month from your plan. And it's important, of course, to plan for paying those monthly charges that you're going to get from your healthcare plan. The reality is that if you don't, you are at risk of being terminated from this smoothing program and then being required to pay your copayments at the pharmacy counter. So, very important to understand that even though smoothing is a benefit, it doesn't replace or limit the total amount of copayments that you're ultimately going to have to pay. So you have to plan to actually make those payments over the course of the year. Okay, next slide. So this tells you a little bit about what might happen if you don't make the payments. You will be billed in the first instance by the plan, and then you will receive a grace period thereafter where there is no interest charge. But if you don't pay in full by the end of the grace period, you will be terminated from the smoothing program. That doesn't mean that you will lose your Part D coverage. If you get into a situation where you can't both pay the Medicare Part D premiums that you owe and these smoothing bills that come in monthly, please make sure that you prioritize paying the Part D premiums first, because that's what will keep the insurance coverage in place. So if you are in a difficult situation, you have to choose between the two, make sure that you pay the Medicare Part D premiums first. All right, let's go to the next slide. It's also true that if you're getting some forms of other assistance, those other private insurance or other private mechanisms for assistance may require you now to apply for the smoothing benefit as a condition of your getting that other assistance. That is not true for Accessia. Accessia is not going to condition the assistance it gives on whether you sign up for smoothing or not. But other assistance programs, particularly manufacturer assistance programs like free drug programs, probably are, in many cases, going to condition their assistance to you on your opting in for smoothing. So please be aware of changes in the conditions that apply for all of your assistance programs, and be in particular on guard for the possibility that those other assistance programs might be requiring you to opt into smoothing. All right, next slide. So here are a whole bunch of resources to learn more about the Medicare prescription payment plan. There's a fact sheet that Medicare has on this. There are takeaway tear-off sheets or cards that you're going to be potentially handed at the pharmacy counter as a way of giving you some shorthand information if this issue comes up at the pharmacy counter. The Medicare.gov site has a wizard function which will help you determine whether smoothing is right for you. You can put in the list of medications you have, and it will help you calculate what it looks like both with and without smoothing for you. So that could help you quite easily determine whether this is a benefit that makes sense in your particular circumstances. In addition, on Medicare Plan Finder, the cost preview feature allows you to compare what your monthly costs for your drugs would be both with and without smoothing. There's some more information, some high-level information on smoothing in the Medicare and You handbook. And then there are some terrific private options, non-CMS, non-government sources of information on this smoothing program. One that I think is particularly good is from the company Patient. And so we have the link there. That may be a very useful resource in kind of walking you through your options and how to choose what's right for you. All right. The next thing that we want to talk about is premium stabilization for standalone prescription drug plans, or PDPs. So, two different ways that people get their Medicare Part D coverage. One version is that they get their Medicare Part D drug coverage through their Medicare Advantage plan that covers all the rest of their Medicare needs. Some people, though, actually have a separate Medicare Part D plan that only provides for them their Medicare Part D drug coverage. And those are the standalone plans. So if you have a standalone plan, the folks at CMS calculated what your premiums would look like next year. And initially, it did not look very good. There were some very significant premium increases that were expected. So what the government did was put together a demonstration program that is allowing virtually all of these standalone prescription drug plans to accept additional subsidies from the federal government in exchange for reducing the premiums that you're expected to pay next year. So this is good news. You don't have to opt in. Your plan has to opt in. And even better, virtually every applicable program has already opted in. So you shouldn't see the increases that you otherwise would have, but for this demonstration program. So good news here again. All right. This particular slide is really a reminder slide. These particular elements of the Inflation Reduction Act were already effective, have been already effective, but importantly, you can get no-cost vaccines through any Part D plan, so long as it's a vaccine that is recommended by a particular organization that is referenced in the statute. This is a fantastic thing. It allows you access to vaccines without any cost sharing, deductible, co-insurance, co-payment. Examples include the shingles vaccine and RSV. There are others as well. So terrific benefit that hopefully will encourage folks who would benefit from a vaccine to go ahead and make sure that they are vaccinated in a timely fashion. Another pre-existing benefit introduced earlier in the implementation cycle for the IRA is, of course, the cap on the monthly cost associated with insulin. There, the cap is $35 as a maximum for a month's supply for each covered insulin product. So if you're on more than one insulin product, you may in fact have out-of-pocket costs per month that are greater than $35 because this is a cap that is per covered insulin product, but still a terrific development for those diabetics who are insulin dependent. All right. Yet another thing that changes in the Inflation Reduction Act is that manufacturers are now subject to having to pay additional rebates back to the Medicare program if their prices for their drugs increase faster than the rate of inflation. So this is an attempt by the government to have some additional pressure on manufacturer pricing of their drugs. This provision has a benefit to Medicare Part D beneficiaries like you. What happens here is that you end up, as a consequence of the application of these rebates, paying co-payments or co-insurance based on the post-rebate, the lower price that now applies after the Medicare program has collected that rebate from the manufacturer. So this is good news. It should also help in a variety of different circumstances to reduce, in this particular case, not just your Medicare Part D drugs, but also your Medicare Part B drugs. Those drugs which require generally practitioner assistance in order to inject or infuse those drugs. Now, one little tiny word of caution here as well. The changes to co-payments and co-insurance that can come as a function of this change aren't necessarily precisely the same from month to month, because again, the formula is a bit complicated. It may be that your co-payment in 1 month is not a perfect predictor of what your co-payment will be the next time you receive that same drug. So don't be surprised if there's some variation notwithstanding the application of this particular provision. All right. And then the last thing that we're going to cover today before we get to some of your questions is this notion, probably for many of us, the part of the Inflation Reduction Act that we hear about the most. And this is the notion that the government, the Centers for Medicare and Medicaid Services, can directly negotiate for the first time with manufacturers over the pricing of at least some of their drugs. So we've just completed the first round of negotiation for the first group of Medicare drugs. These were 10 Medicare Part D covered drugs. Notwithstanding the fact that we have completed the negotiation process and now we have negotiated prices for these drugs, those prices don't actually apply until January 1 of 2026. So there will be some good news beginning January 1, 2026, and unfortunately, again, maybe a little less good news at the same time. So let's focus first on the good news. These lower negotiated prices, again, will be used to determine your out-of-pocket costs. So to the extent that the government has negotiated lower prices than previously applied, that should translate into lower copayments if you continue to use those drugs beginning January 1, 2026. A little less good news here. The reality is that the plans, the Medicare Part D plans, their pharmacy benefit managers, and a number of providers out there will actually make less money on these negotiated drugs than on therapeutically equivalent drugs in the same class of drug. So that unfortunately creates some risk that the plans, the pharmacy benefit managers, and some providers will want to switch Medicare Part D beneficiaries who use these drugs to other therapeutically equivalent drugs that they can make more money off of. I wish that were not true, but unfortunately, that economic incentive exists. And I think we can reasonably predict that at least some actors out there in the Part D world are going to try to switch you if you are on one of these initially selected 10 drugs. All right. That's a little upsetting, I'm sure. But so the first thing to do is to breathe. This is something that is not going to happen this January 1. If it happens, it's going to happen a year from that January 1. And there are going to be things that you and others can do to stay on your pre-existing drug if that's what's right for you. Among the things that you'll be able to do is to file either a Medicare grievance or appeal, or both, which will put a real check on what the Part D plans themselves do. They're graded based on their grievance and appeals procedures and the outcomes of those grievances and appeals. So it can be really impactful on their decision-making if you file one or both of those. And there will be people, your providers, your pharmacy, and of course, the reimbursement lines for the manufacturers of your existing products who will be available to help you file those grievances and appeals if, in fact, you think that someone's effort to switch you is not in your best interests. Next slide. So looking forward, this is an issue potentially that could grow more important over time, and that's because we will have more and more drugs subject to negotiation over time. In 2027, 15 more drugs will be added to the group of negotiated drugs. In 2028 and thereafter, it's 20 more drugs each year. So again, some very good news there in the sense that that means that more and more drugs will probably be subject to lower and lower cost sharing as a consequence of these negotiated prices coming online. For some period of time, it also means, though, that there might be more pressure to switch patients. But at some point, there will be so many drugs subject to negotiated pricing that the plans, the PBMs, the providers who might otherwise be interested in switching you will sort of run out of options to switch you to. All of the drugs, or nearly all of the drugs in a particular class, will now be subject to negotiated pricing. And so there won't be any longer an economic incentive to switch you to a different drug. So you need to sort of keep your eye on this, make sure that you aren't being the subject of an unwanted switch. And again, there will be lots of resources through your provider, through your pharmacy, through reimbursement lines for the drugs that support your existing treatment options that can help you navigate this. And for now, the best news is not a problem this January 1, only a potential problem next January 1, 2026. Okay. So what are the first 10 drugs that might be first subject to these sets of issues? There they are. And so if you're not using one of these drugs, then the copayment reduction that may come from the negotiated price is not an upside for you, but you also don't have to worry about a switch that might be based upon the incentives that are created here. Next slide. All right. The very last thing that we'll cover before you get to your question, before we get to your questions, is that one of the big picture changes under the Inflation Reduction Act is that the plans themselves are expected to be more financially responsible for all of the Part D costs. And they are going to be facing certain significant implementation challenges. They've got to make this new payment system work. There's going to be a third-party contractor that's going to be responsible for these negotiated prices known as Medicare fair prices. That contractor is going to be totally new when we get to this system. And so there's a risk that your pharmacies will be experiencing slow pay problems. They won't be getting their reimbursement as quickly as they have in the past. And this could create some transition issues. So you want to try to minimize the extent to which you're dependent upon a refill in January, frankly, probably both in 2025 and 2026, in order to try and make sure that you don't get caught up in some of these transition issues. If you can manage your medications so that you're not getting a refill in January, maybe even February, that's possible, that will help insulate you from what otherwise might be some transition issues that occur in the first couple of months of both 2025 and 2026. Next slide. As a consequence of this same issue, that the plans are more responsible for the overall costs of the program, the government less responsible for the overall costs, it's very likely that we are going to see the Part D plans do more in the way of what they call utilization management. So these are a bunch of steps that plans can take that create some barrier to your accessing the drug that your practitioner has prescribed for you. There are various things that plans can do. They can do prior authorizations, which require the prescriber to submit certain information about why this drug is medically appropriate for you before coverage for the drug is provided. They can do what are called fail first requirements, which require you to use another drug product before you have coverage for the one that your practitioner actually prescribed in the first instance. And there are other utilization management mechanisms that might come into play as well. And unfortunately, these are going to be more prevalent in light of the Inflation Reduction Act changes. What can you do if you're facing one of these barriers? Well, both your practitioner and your pharmacy are terrific resources in helping you deal with these issues where they arise. And the reimbursement line for whatever drug maker is responsible for the drug that you're trying to get access to can also be a terrific help. If you're denied access to your drug, you should therefore work with your prescriber, your pharmacy, and potentially the drug maker's reimbursement line in order to file grievances, file appeals, and really fight for your right to access to the drug that you and your prescriber think is the right treatment for you. Remember, as in all things in life, the squeaky wheel is the one that does best. So if you find yourself burdened with these sorts of utilization management mechanisms, and you think that they're being applied unfairly and keeping you from accessing the right drug for you, don't be afraid to be a squeaky wheel and help with providing the right information to your prescriber, to your pharmacy, and to others. Give them the information to help be squeaky for you too. Okay. So we conclude with some resources. We've previously talked about some resources that are specific to a couple of the different benefits that the Inflation Reduction Act brings. Here are some more global oriented resources, one that sort of covers Inflation Reduction Act issues, all of them broadly, and the second, of course, which is the official handbook for the Medicare program, and has resources on all aspects of the Medicare program. And then there's, of course, a code there that you can use to access the educational content that Accessia has made available to you. So hopefully all of that will inform you and lead you to make good choices here that will support your health, which is what Accessia is focused on and wants to help you achieve. So thank you to Accessia for sponsoring today's educational session in part one with our friends from CMS, which was a terrific presentation as well. And now we come to questions.
They're here. We're at the question time frame. We're going to start with extra help, Bill. Do saving accounts count towards monthly income when considering extra help?
I will check on the answer to that. I do not believe that there is a carve out for HSAs, as they're commonly known, and I believe that that would count towards your monthly income, but we will check on that and we will make that answer available to everyone.
Absolutely. Will the insurance company still be able to lower the tier level of a prescription drug if the subscriber or doctor requests?
Yes, you can still make those sorts of requests, and the plan is obligated to consider those requests. This is one of the things that maybe gets a little more complicated if I'm right, and I'm the world's greatest pessimist, as probably this presentation reflects. But as a pessimist, I do think that because the plans are forced to honor that $2,000 cap, they're probably going to be interested in finding ways to get other people closer to that $2,000 figure. And so they may be a little less likely to think about those sort of tier adjustments in that world.
Unfortunate. There are a good bit of questions about the smoothing benefit. Will the smoothing benefit need to be an option that they select every year?
Oh, unfortunately, yes. The Medicare Part D program, as everyone knows, kind of operates on that annual basis. And unfortunately, yes, you have to opt in each year. You know, to be fair to CMS and to be fair to the legislation, there's, some good reason to require that, because your circumstances one year aren't necessarily a great predictor of what your circumstances are the next year. And so the benefit might make sense one year and not make sense the next year.
Yes. What if someone's spouse opts in to make payments, but early in the year, unfortunately, they pass away? Does the payment still need to be paid through the end of the year or in a lump sum, or is it adjusted?
Well, that's a great question. You can opt out of smoothing at any point. So in that circumstance, if, for instance, as part of an estate resolution, you wanted to opt out and then pay it all at once, you could do that. Alternatively, you could maintain the smoothing and pay it out through the rest of the year. So you have some options to consider there.
In the second example of smoothing, it indicated that about 50% of the entire cost was due later in that Q4 2025 timeframe. What is the expectation on abandonment rate during that quarter?
Well, that is the scary thing here for me as somebody who worries about patients. My worry is that if people don't focus on whether this really makes sense for them or not up front, they might not make a great selection. And then they hit a circumstance where late in the year, they're actually paying more that month, at least, than they otherwise would. And now maybe they say, well, I can't afford the drug.
Right.
So we need to be as thoughtful as we can up front, make good choices, and think about what makes the most sense throughout the whole year, not just that first month when we're thinking about it.
And this next question goes along with that, right? We talked about making sure that you are able to make those payments monthly if a patient opts in to pay. And then for some unforeseen reason, they cannot continue that payment plan option. What is the next step for that person after that grace period ends? Will they have to be billed for the amount until they pay what they've accrued? What are their options?
Well, um, the Centers for Medicare and Medicaid Services and the plans are not being quite as direct about that as perhaps they could be. And there may be various reasons why it's not entirely clear what that circumstance will yield. The part we know is that you'll be billed for the full amount after the grace period. What then will happen is a little bit of a question mark. I think the thing that I want to stress is that you need to make sure, no matter what happens, that you have prioritized paying your Part D premiums every month, because that's what your coverage is tied to. And so you don't want to pay something towards smoothing but end up losing your coverage for the rest of the year.
Right. Are there medications or drugs that are excluded from the payment plan option?
No, it covers all covered drugs under the Medicare Part D program. I suppose some are excluded in the sense that there are no out-of-pocket costs associated with them, like, for instance, those recommended vaccines.
Great. Does the out-of-pocket cap apply to Medicare Advantage plans?
Well, it applies to the Medicare Part D coverage of Medicare Advantage plans, but it doesn't go to all of those non-pharmaceutical, non-Part D benefits that you may be receiving through Medicare Advantage. The regular coverage and copayment, coinsurance obligations that are associated with that Medicare Advantage plan will continue to apply for those non-Medicare Part D drug items and services.
Yes. And I think we've received this next question quite a bit as individuals worry about, okay, there's a cap on this. Are the insurance companies going to try recouping their funds elsewhere? So, is it true that insurance companies will increase premiums in an attempt to offset loss from these programs?
Well, longer term, unfortunately, yes, that is yet another possible unintended consequence of some of these Inflation Reduction Act changes. Again, wearing my ever-present pessimist suit, I am worried about that. Yes, that's why we see the premium stabilization program for this year and a couple of years beyond that. But there does seem, unfortunately, to be growing pressure on premium increases, which could play out, unfortunately, in a negative way over time.
It's a concern. We'll have to keep our eyes open for that one. With the inability to opt in for the prescription payment plan at the pharmacy, if a patient goes to the pharmacy, they can't afford the deductible or the copay, whatever is due at that time, and they call insurance to opt in. They're at the counter, they're opting in. How long until they receive their medication? Is it immediate?
Yeah, I hope it will be immediate, but that's one of the transition risks. Again, wearing my pessimist hat, my guess is that it is going to be less immediate in January and February than it might be in subsequent months. There are going to be, I think, some transition issues. So really what you want to do is you want to think about this as you're enrolling for the year or before January 1, as the case may be, and make as good a decision as you can, at least for that point in time. Circumstances might change. Maybe in March you're on an expensive product that you didn't anticipate and things have changed. Well, you can reconsider your decision then, but take action now. Start informing yourself. Use Plan Finder, use Wizard, figure out whether it makes sense or doesn't make sense, at least based on what you know now, to be in this program or not in this program, and take action.
Definitely say use the resources that are available during this open enrollment time, as open enrollment is coming up in just 5 days. We are at the top of the hour. There are some questions that we did not get to. However, we will type up those answers and share them on our website. Bill, as always, we thank you for your expertise and your time. We are so happy to have you with us to discuss this very important topic, as Medicare changes are right around the corner. We
Well,
thank each of our listeners too.
Well, I just want to thank you and Accessia. What a terrific organization. You're a fantastic leader. Everyone there is so committed to the patient, and it's always been my privilege to be associated with you. So thank you.
Thank you so much, Bill. Thank you. And to our viewers, we hope that you answer the survey at the end of this webinar, and be sure to follow us on social media at Accessia Health. Again, thank you and have a great day.